Without taking much time, I would like to invite Dr. Sampath Gnanaratne to take the podium.
Thank you very much, Dr. Kandy Singh, the president of KSM. And today's topic is right to the right to a better world, contraception. And when you when we talk about contraception, as Kanchana said, it's known. I mean, it's a fact that the world population is towards the rising side. It's 7 billions at the moment. Population is growing. At the same time, humans are consuming natural resources, and then it's becoming a global problem. On the other hand, the social requirement, the economic requirement, and lots of other factors affect this. There are some people who they don't want to have children. On the other hand, there are some people they want to keep space between their children. Therefore, knowing about contraception is an essential part in modern life. And as I said earlier, the layout of my lecture will be initially the some history about contraception, and after that the different types of contraception and common conditions where we come across during our day-to-day practice, and then the non-contraceptive advantages of some contraceptions as contraceptive methods, as well as you eagerly waiting, the last part will be about emergency contraceptives. All right. And when we talk about history of contraception, and it extends to ancient Egypt back in 1850 BC, and during those period, and the people were using honey and acacia leaves to block the cervix, and it has proven some giving kind of protection for sexual intercourse. And 7th century BC, China and India, they use coitus reservatus and coitus obstructus and prevent ejaculation to protect being pregnant. And apart from that, during those periods, people were knowing about the prolonged breastfeeding create amenorrhea and anovulation. Therefore, some communities they practice exclusive breastfeeding for up to 3 years to stop the conception, as well as it was used as one of the methods of contraceptives. When we come to modern world, it is a like a right to learn, a right to express their views. Like it is a kind of fundamental requirement of human being, and at the same time, the WHO define it as one of the Millennium Development Goal. It's not moving. All right. Yeah. And there are some terms and things it is important to know when you go through this lecture, and let me to take you through those terms and kind of uh, mm, conditions like this what we call unmet need. There are 7 millions of women all over the world, and they don't want to have children. At the same time, some of them they want to keep a kind of space between their children, and but they are sexually active. Therefore, this is the most kind of vulnerable group of people. They call unmet need. People they want contraception, but they don't have access to have a better kind of contraception. Therefore, it depends on the country's health system, social conditions, support of women's, and that's need supports to women to choose their contraception. On the other hand, in Sri Lanka, it is the condition. And Sri Lanka also, when we see the population, I mean the consumption of contraceptives, the middle-aged women are the people who don't use contraceptive because they are not having regular sexual interactions. At the same time, they are they are not intent to they have not they don't have any intention to have another child, but they are sexually active. But once they get pregnant, there's a huge problem. The social issues, that the family issues. Sometimes their children are grown up. They are sometimes some parents, some women are they are having grandchildren. Therefore, that is why they are going for termination of pregnancies and lots of unethical and unnecessary kind of activities. Therefore, it is important to address those group of people as well. As clinician, what is our responsibility? Women should be given accurate information about all methods which help to decide, but suit the the the, the, the requirement according to their requirement. Health professionals competent of giving informations about the efficacy, risk, and side effects, advantages and disadvantages. At the same time, non-contraceptive benefits of available method. And when we talk about efficacy of contraceptives, efficacy, there are kind of uh, concept in contraceptives. This this is called there's a two methods of uh, kind of assessing. The one method is typical user. The other thing is perfect user. The typical user is a use where it's in kind of laboratory, the ideal circumstances. Usually the ordinary person who get involved with day-to-day activities and usual their occupation and social responsibilities, it is quite difficult to someone to get adhere to this typical kind of recommendations and rules and regulation. Then the other one is the perfect user. The perfect user is the one which we use. Sorry, this should be the other way around. The perfect user is the one person is using in recommended circumstances. Typical use is the one we use with day-to-day activities. Therefore, there are some kind of contraceptives. Then it's depend on the person's compliance. Therefore, there's a big difference between typical user and the perfect user, especially for male condoms. The perfect user, the failure rate is 2%. But when it comes to the practical world, the failure rate is much higher. The failure rate is 15%. Then pill, patches and rings. The person use those things whenever they needs, they use. They forget, sometimes they don't use, sometimes they are the personal preferences. Therefore, the the typical user significantly deviate from perfect user. I don't know. All right. The perfect use and typical use. And then we can divide contraceptives into two groups here. There's a based on this we divide contraceptives to one category, that is user dependent. The other category user independent. User dependent category like male condoms, pills, patches, rings. There's a wide gap between typical user and the perfect user. There are another sets of contraceptives that is called user independent contraceptives. They are, for example, the intrauterine devices or a female sterilization. In those kind of situations, the person no need to remember things and no need to uh, just to adhere to protocols and rules and regulations before these activities. Therefore, it is user independent. The user independent contraceptive methods are more reliable than the user dependent contraceptive methods. And the next one is a kind of drug interactions. When you talk about contraceptives, there are most of contraceptives are hormones. There are another sets of contraceptives, non-hormonal contraceptives as well. The hormonal contraceptives having kind of interactions when it's in our body. The hormone contraceptives, kind of hormones over medicines what we are on, at the same time medicines on hormones. The 1 or 2 decades ago, our head we use as a storage kind of device. Nowadays we don't use our head as a storage device. We use our brain to analyze things and utilize various kind of resources. Therefore we no need to remember all those kind of interactions as the drugs reactions and things. There are sites, and you can use the one site is Stockley Drug Reactions website, and you can log into those things and get your get it clarified. And there are some occasions uh, where we cannot let that lady to get pregnant. It carries significant health risk to that particular woman. Therefore, most of the time we use the effective methods of contraceptive for these kind of women. That should be a kind of user independent contraception, as I described before. At the same time, the most effective type of contraceptive is we call LARC, that's represent for long acting reversible contraceptive. We use those kind of contraceptives, and when we use contraceptions for a lady who is not suitable for pregnancy, therefore it should be the failure rate should be less than one pregnancy per 100 women years. Then I'll come to that later on, that how to calculate the Pearl index, what we call the Pearl index. And there are some sets of things for a kind of relative contraindications and the relative contraindications. There are sets of things: cystic fibrosis, cardiomyopathy, and epilepsy, and gestational trophoblastic neoplasm, HIV related diseases. And we need to use reliable methods of contraception for these women till their medical condition get sorted out. And the Pearl index, it was introduced at 1930 as a kind of tool to assess the efficacy or the effectiveness of contraception. And it is easy to calculate. Therefore, still it's used as a kind of calculation to represent the efficacy or effectiveness of contraception. it gives as a failure rate of 100 women having unprotected sexual intercourse over 1 year period. That's described as 100 women year. And the rest of the presentation, I'll describe it as kind of we call the medical eligible criteria. When you talk about medical eligible criteria, category 1 is a no contraindications to prescribe that particular contraception to that particular person. It's always no problem with that. Category 2 represent the advantages outweigh the disadvantages. Category 3, in category 3 there are some advantages and disadvantages. Some clinician needs to decide and that particular contraceptive method is suitable for the patient. And category 4 is contraindicated for that particular person. There are some occasions that we need to uh, pay our attention. We come across some kind of difficulties of prescribing, especially there are some occasions I'm going to discuss with you. The breastfeeding, especially, you just imagine 18 years old lady delivered in your unit, she's going to go home, and you need to give kind of reliable method of contraception for that particular lady, at least for 4 or 5 years till she become mature and kind of mentally and physically suitable for her next pregnancy. Therefore, you need to prescribe some kind of proper contraceptive methods, and at the same time you need to pay attention over there's a risk of developing deep vein thrombosis just after the delivery. At the same time, the lady is breastfeeding as well. On these kind of patients, all progesterone only methods are suitable. It comes as category 1. And contraceptive, combined oral contraceptive pills cannot prescribe up to 6 weeks. It comes up to 6 weeks, it's a category 4, therefore contraindicated during pregnancy because it affects breastfeeding as well as it enhances the formation of blood clots as well. After 6 months, 6 weeks to 6 months is category 2. 6 months to 6 months onward it comes category 1. And LNG-IU system and the intrauterine system is a kind of imaging, kind of newer kind of introduction of, that is the concept what we call post placental intrauterine system. Just after removal of placenta, the post placental, we insert copper IUCD. But after 48 hours, you cannot insert this because the uterus become hyperemic and inflamed, and there may be kind of ongoing subclinical infections. There's a chance of perforation of the uterus. Therefore, if you insert a kind of IUCD for a lady who delivers her baby, then you need to insert it within 48 hours, or you need to delay it up to after the 4 weeks. Then after 48 hours up to 4 weeks, the insertion of intrauterine devices become category 4. And obesity is another kind of situation we come across in day-to-day practice. You can use copper and LNG intrauterine systems, progesterone only pills, then implant, DMPA, all those things are category 1. And remember, combined oral contraceptives, if BMI more than 30, it comes to category 2. There are some benefits and risks, and benefits are heavier than the risk. Therefore, you can prescribe it as category 2. But if BMI more than 35, it comes category 3. The disadvantages outweigh the advantages. And epilepsy, so it's not there. This epilepsy is the one, kind of situation we come across day-to-day practice, especially general practitioners. People ask whether they can continue what is the most suitable kind of contraceptive methods that they can use. The copper IUCD and LNG-IU system use without any problem, and implant, DMPA, progesterone only pills and combined hormone contraceptives, all are category 1. Remember, the old anti-epileptics, they are liver enzyme inducers, phenytoin as well as carbamazepine. But newer anti-epileptics, they are having less teratogenic effects as well as they are not very potent liver enzyme inducers. And viral hepatitis, is here, and still you can prescribe whatever the antibiotic, whatever the contraceptive method which is available, copper, IUCD, implant, DMPA, progesterone only pills. But when it comes to combined hormonal contraceptives, the continuation, if person is on combined oral contraceptives, you can continue it. And if it is a category 3, if you are going to initiate, because estrogen causes kind of cholestasis, kind of adverse effects in liver. And HIV, you know, all those kind of things. And the next one is a kind of area we are going to move, the types of contraceptives which is available for the patient. Some contraceptives are not available in Sri Lanka, but some are available. I will go through this thing quickly. And intrauterine system, this is, there are two methods. One is copper IUCD, the other one is levonorgestrel releasing intrauterine system. And copper IUCD, when you talk about copper IUCD, it's a kind of gadget which contain copper. The duration and efficacy of the contraception depend on the amount of copper which contain in that particular device. It's when you use copper 380, you can use it for 10 years if it's and is one of the best contraceptive method. There's a misunderstanding over the society and sometimes doctors as well. The IUCD increases the occurrence of ectopic pregnancy, but it is it's a misconception. It reduces the number of conceptions, so it reduces the ectopic pregnancies as well. The one thing that you need to remember is, if someone got pregnant while on IUCD, there's a chance of having an ectopic, the higher chance of getting an ectopic. And it's a quite efficient kind of contraception, and it's very cheap as well, with very suitable method for country like us. At the moment, the efficacy is quite significant. And the second one is levonorgestrel releasing intrauterine system, that is also intrauterine system. And there are two types of intrauterine systems. The 13.5 milligrams device is just introduced and is under trial at the moment. And what we use regularly even in Sri Lanka, the LNG intrauterine system, 52 milligrams one, Myrina. And remember, this is the primary indication is not contraception, because there are thousands and more other cheaper methods for contraception. It has lots of non-contraceptive benefits, like it reduces the menstrual flow and improve dysmenorrhea and create some amenorrhea, and we can use it for adenomyosis and all those kind of medical. And it's a kind of progesterone releaser for HRT. We can give estrogen alone orally and put and I use LNG IU system to uterus to get the protection for endometrium. Therefore, it's not a primary indication. Using LNG IU is not a primary indication for contraception. And when you talk about intrauterine system and contraindications, only thing is that if cervix is distorted and any problem with the cervix, you cannot insert it. At the same time, pelvic infection, remember, if someone is in PID or something, these common things, you don't need to remember those things, and you can work it out. And therefore, the next kind of contraception, progesterone only contraception, progesterone only contraceptives. It consists of several, the implant and progesterone only injectable, like we call depot, and progesterone only pills. And when you go, the progesterone only pills is the northisterone, levonorgestrel, and desogestrel. It's usually it's not available in Sri Lanka as far as my knowledge. I don't think it is available, but for your knowledge, I just put. And it has we can use this for people who don't, I mean, not suitable to use combined oral contraceptives. It has a kind of poor cycle control. The person needs to get the medicine the same time, same day. If she misses it for several hours, there may be some uh, breakthrough bleeding and contraceptive failure as well. And the other one is DMPA. It's a kind of medicine which is I mean widely used in Sri Lanka, and it's a kind of very old kind of medicine. 1970s, 80s is one of the most popular kind of contraception, and we call depot medroxyprogesterone acetate. At the same time, this IM preparation is lots of side effects. It take ages to clean it from the body. Therefore, the recovery from that particular regain the fertility from particular medicine becoming it takes more and more time. At the same time, therefore, it creates lots of other side effects like breast tenderness, oily skin, then there bloating, and lots of progesterone side effects and weight gaining as well. Therefore, it better to avoid those, though it is cheap and widely available. There's another preparation recently launched. It's popular in other countries. The self-administration kind of intradermal contraception, DMPA. The Mirena is, I put it there as is a progesterone only kind of contraception. Another one is progesterone implant. There are two types, implanon and jadil. They know jadil contains two rods. And remember, sometimes it is kind of two rods release eterogestrol. It's easy to insert this gadget, but it may be difficult to remove. Sometimes it cannot be removed at all. Therefore, person who is not pregnant at all and not having even a single kid, it's better to avoid this rather than putting this one, because sometimes it can get dislodged somewhere and it's quite difficult to find it out. And progesterone only contraceptives, the contraindications for these, remember, if someone is having carcinoma of breast cancer, we cannot use that. And VTE, venous thromboembolism, we cannot use that. Decompensated cirrhosis, because those things get metabolized, they are in liver. The commoner and popular things, the combined contraceptive pills or kind of contraceptives, and there are some preparations. The medicines comes as in transdermal patches and vaginal rings, as well as pills, what we know, the oral contraceptive pills. And when you talk about oral contraceptives, there's a kind of preparations we call monophasic or biphasic and triphasic, and sometimes is a quadriphasic as well. But in the market, the biphasic and triphasic contraceptives are popular, and it's try to mimic the hormonal change of a woman's body. The initially it's the people thought triphasic will take over biphasics very easily, but with meta-analysis and lots of researchers, it has given this, the systemic review, the efficacy and dropout rates and side effect profile. There's no difference between biphasic against triphasic, but people who are getting triphasic contraceptives are having better cycle control. It means they are having less breakthrough bleeding. They don't get haphazard bleeding like as common as biphasic contraceptives, but contraceptive efficacy is same in both categories. And couple of years back, there was a kind of practice. It is contraindicated like thing to prescribe combined oral contraceptive women over the age of 40 years. But it is not. There are enough and more evidence. It is quite safe of prescribing women after 40 years as well. And there's another one. There's a kind of thing. Recently, I mean, I came across while I was listening to kind of presentation. COCP can be used as hormonal HRT as well. Yes, if a woman is not having vasomotor symptoms while using combined oral contraceptives, we can let that lady to continue it. One reason is she's having symptoms free of symptoms free of using combined oral contraceptives. At the same time, when we use conventional hormonal package in Sri Lanka, it it costs roughly 5,000 to 6,000 rupees. But combined oral contraceptive, I mean the best kind of preparation which contain 2,000 rupees, 3,000 rupees, because cost effective as well. But to replace hormones for a woman, you need to give at least 1 or 2 milligram ethinyl estradiol. But this contraceptive contains 0.35. It means 350 micrograms of contraceptive. But the person is free of symptoms, no need to change, and we can let the person to continue oral contraceptives as it is cheaper as well accepted nowadays. And there's a slight risk of developing VTE, and it is higher with third generation progesterone containing contraceptives. And common contraindications for combined oral contraceptives: postpartum up to 4 weeks, as I said, BMI more than 35, and hypertension, stroke, organ transplant with graft rejection, VTE, and migraine with overa. And the common contraindications: current and past breast cancer, BRCA1, BRCA2 mutation. It is available for the people who want to screening in Sri Lanka. If someone is having BRCA kind of breast cancer in family, who's a develop uh, in younger ages, and diabetes with nephropathy, and antiphospholipid syndrome, and things. And the last topic, that's a method of contraceptive, the barrier methods. The condoms. And when I go through this slide, I got a bit amused. With there are various kind of contraceptives: the delayed one, ultra thin one, thick one, flavored one. The what I cannot remember understand is the glow in dark, the one which glow in the dark. Just imagine, just the person who is having kind of this kind of one, isn't it? It's nice. It's available here, Sendil. Yeah. And when you talk about contraceptives, remember the sterilization. I mean, we don't talk about sterilization most of the time, but because now in the modern contraceptives, we don't talk sterilization. That is because the life keep changing all the time. The person, once you perform LRTO, ligation and resection of tubes, the woman is, having less chance of less opportunities in her life. Therefore, it's better to avoid below the age of 40 years. At the same time, if someone is having kind of severe kind of problem, the woman is having significant heart disease or any other problem, and we always try to sterilize the woman, and we get the risk and discuss with various people and book an ICU and all those kind of. But you need to consider giving kind of counseling the man as well. Then you can go for vasectomy. The person is fit and well. And there's a next topic, but we are going to discuss it. Is the most important topic for the general public, where you get day-to-day kind of problems. We call emergency contraceptives. When you talk about emergency contraceptives, there are two methods widely used. One thing is the copper bearing IUCD, and it's a copper IUCD. The other one is oral emergency contraceptives. And when among these two, copper IUCD is the best method which is available, and is quite reliable as well. It can be inserted within 5 days of sexual intercourse. Therefore, within 120 hours of unprotected sexual intercourse or kind of that incident. And it has given another period of grace and that is if the woman is having sexual intercourse in first half of her menstrual cycle, and if she has exceeded the first five 5 days after the intercourse, but still she is within 5 days of her expected date of ovulation, then still you can go for insertion of IUCD. It is still giving kind of protection. I think it is clear, and you can insert the IUCD within 5 days of estimated date of ovulation, though she exceed more than 5 days of her last sexual intercourse. And the other thing is oral emergency contraceptives. This ulipristal acetate is a kind of steroid, synthetic steroid, and it's a progesterone receptor modulator. It's available in other countries over the counter. We can use. At the same time, what is available in Sri Lanka is, everyone knows, an oral progesterone only. We have levonorgestrel 1.5 grams. We call Postino. We can give it up to 72 hours. The ideal use within 72 hours, but you can go up to 5 days. There are some kind of protection over that. And we are reaching the last part of our kind of discussion, and the one common thing what we face, the misfill, the day-to-day practice we get. The women are having lots of kind of commitment nowadays. There's some people, they cannot remember to get the contraceptive pill every day, and therefore if there are two methods, if it is within 24 hours, what you can ask it, the lady needs to get the forgotten pill the time she remember that, and she needs to continue her, she needs to get her usual pill on due time the particular day, the same day she is getting two tablets. If it is more than 24 hours, it means if she misses more than two pills, she need to get the one pill whenever she remember that she forgotten that, then at the same time she needs to get the pill on that particular time, due time, and she need to continue it as usual. Remember, if someone if someone forgot more than two pills, that there's no contraceptive protection is obtained from that particular method. Therefore, you advise them to use barrier method until she gets 7 tablet in a row. Then that particular oral contraceptive pills will provide kind of protection over there from that particular point onward. And that is it basically regarding contraceptives and things. And if you have any question or any kind of gray areas, I'm happy to discuss things with you. I think it's crystal clear.
Any questions?
Jolly තමයි හැමදාම ප්‍රශ්න කරන්නේ. අමාරු ප්‍රශ්න.
Sampath, thank you for that very interesting and elaborate presentation. We come across females with polycystic ovary syndrome, where we use contraceptives to reduce the androgenization in those patients. So when we use those contraceptives like this ciprofloxacin acetate and ethinyl quantified like diet or something like that, some of these patients, they develop this breakthrough bleeding. So how do we overcome that? And then when do we restart the second listing? So we say that when they get their period after stopping the 21 tablets, they will get their period, and when they get the period to start the second time. But some patients, they don't get it even by 7 days. So these kind of issues, how do you encounter these problems when you prescribe these patients?
Yeah, we do prescribe oral contraceptive pills for people who are polycystic ovarian disease and things. The aim of the physiology of this giving this thing is, once you give oral contraceptive pills, it increases the sex hormone binding globulin in our body, and so reduces the amount of circulating androgens, and at the same time it contains anti-androgens as well, lots of newer kind of things. And the first question is kind of we use the some COCPs which originally designed for kind of, it's kind of COCP originally designed for polycystic ovarian disease, that is actual DAN 35. uh, it's not a, it's not a contraceptive. Actually the medicine was designed for polycystic ovarian disease. The first thing is the if someone develop breakthrough bleeding, the poor compliance and drug interactions. Second one, third one, some people though we prescribe 0.35 0.35 kind of estrogen, it is not enough. Some contraceptives in some other countries it's available 0.5 microgram containing estrogen preparation, then we can prescribe those kind of contraceptive kind of pills to those people. That is the answer for first question. The second question, Charlie, as far as I know, I mean we don't need to stay until the patient develop periods to start the second pack. We give in a row the 21 tablets and we stay 7 days, and we can start the second pack straight away after 8 day onward, whether the patient get periods or not. And at the same time there's a kind of treating polycystic ovarian disease is not a kind of a disease where the physician alone can manage, like diabetes, as you do day-to-day practice. Then patients compliance, patients dedication, reduce her weight, and lifestyle modification and dietary modification, all those things are quite important to overcome problem. But weight reduction is one of the main pillar of treating those people. And unfortunately 50 micrograms containing COCP we don't have now in Sri Lanka. Earlier it was available in Mithuri, green or something like that, but on the other hand we cannot prescribe those tablets to the people who are having PCOS because it's contain second generation progesterone, not anti-androgen. Do I any other?
One more question. So, usually when it comes to contraceptives, we think about only the female more than the male. But now I heard that they have discovered a male contraceptive which reduces sperm motility. Have you any idea as to how it works? There's a new contraceptive method which is used in males, a tablet which reduces sperm motility. Very recent.
To be honest, I heard about sorry, I didn't the one things I don't know about that. The first thing, we use spermicidal gels and all those kind of, even female diaphragms in other countries they use, there's a spermicidal gels are there. And for globally there's not a problem with the male fraction. The globally the male the quality of sperm of males are deteriorating over the period of time, and therefore uh, to be honest the Charlie's kind of thing, I'll read about that because I'm not aware of.
I mean, globally, males are deteriorating.
But at the same time the WHO, at the same time WHO is in towards, I think main the majority of people who are in WHO, I think the working committee are males, therefore they are bringing down the cutoffs of SFA every 10 year. Initially it was the 20 millions to tell the oligospermia. Recently it brought down to the 15 millions. Near future they will bring down to 10 millions as well. Any other question, Mr. President?
very private.
Anyone else any questions?
Sampath,
Yeah.
said that breastfeeding is an ancient method of contraceptive method in a way.
Mm.
Some mothers come and they that they are doing that way. So how effective that is and what is the failure?
No, it is in breastfeeding. It increase prolactin level. At the same time, it make the cervix and all those kind of things atrophy, and it create anovulation. And it is not a kind of reliable contraceptive methods in modern world. As I mentioned there, the thing is sometimes breastfeeding women come, they come and complain they are subfertile, but still they are breastfeeding. At the same time, they are getting irregular periods. Yes, all those kind of things mostly because of breastfeeding. But this in here I raise this kind of matter. Even those days, people were aware this prolonged breastfeeding, and even in our country, I mean in 19th century or to 18th century, people, the breastfeeding is the one they try to the practice what they have practiced to keep kind of space between children. People who are breastfeeding, exclusive breastfeeding, they have the wider gap between their children. But this is not a reliable method to practice in modern world, I think. Like, you know.
Is it till the ovulation begins? It is safe, is it? Generally, I mean, when the postpartum period, till the first ovulation. I mean, first in the sense,
Menstruation, you mean?
menstruation.
Yep. Actually, sometimes some people can ovulate even without menstruation. That is the other problem, other this bad side of this story. And the woman is the lady is assuming that she is not getting periods because of she is breastfeeding by the time she got pregnant. And because sometimes there may be ovulation without having menstruation. This presence of menstruation does not mean that is she's ovulating all the time.